Good morning, everyone. This is Elizabeth. I have 9:30, so I'm going to go ahead and get started. Thank you all for joining us right after a holiday weekend. I hope you got to relax. I know I really enjoyed it. I needed it. I needed a good day to relax. I just have one short note. The state media campaign promoting Quit Now Kentucky, the state's quit line, has just started today. So keep a lookout on digital media, radio. You might have heard some about the press release that went out. For example, I saw on my Facebook feed this morning the one about quitting cold turkey, which I think is kind of cute. So keep an eye out for those. They also incorporate an element of text messaging to enroll. So keep an eye out for that as well. And as a reminder, when it comes to nicotine replacement therapy, at this time, the Quit Line is providing 4 weeks of nicotine replacement therapy to those who are uninsured or to those who have Medicare, because we know there is a gap in NRT coverage with Medicare plans. But for anyone who has Medicaid, a managed care organization, Medicaid plan, or private insurance, we're sending them to their insurer for their cessation benefit. And speaking of tobacco cessation, our speaker today is Dr. Amanda Fallin-Bennett with the University of Kentucky's Breathe team. She has done some extensive work on substance abuse and tobacco cessation and how they work together. I am going to go ahead and turn this over and make her the presenter and mute myself so you all can't hear me. Since all of you all listening are on mute, if you have any questions, go ahead and type them into the question box, and Amanda and I will be able to see those and be able to answer those. So with that, I'm going to turn this on over. Amanda, you should be good to go.
All right, thank you, Elizabeth. Good morning, everyone. Like Elizabeth mentioned, I'm Amanda Fallin-Bennett. I see a lot of familiar names on this call, but just in case, for those of you who don't know me, I am with the UK College of Nursing, with the Breed and the perinatal research team, and I'm also on the board of Voices of Hope, which is a nonprofit organization dedicated to promoting long-term recovery from substance use disorders. And I'm really excited to talk to you today about the link between tobacco and recovery from substance use disorder, because I feel that a lot of times we overlook this important element. So I'm speaking to people who work in tobacco control, so this does not come as a surprise to you, but the tobacco control efforts have been widely successful public health interventions. It's on par with vaccines, what you've all accomplished in terms of saving lives through tobacco control. So if we look back, 1964, that was the first Surgeon General's report on the harms of smoking. And since that time, you all have saved 8 million lives with your tobacco treatment, with smoke-free laws, and with tobacco taxes. But at the same time, 70 million lives were still lost since 1964. And we know, everyone now knows, about the harms of smoking, and we've, really done a lot to help people quit, but smoking is now concentrated in disadvantaged populations. And one of those groups that unfortunately still has very high rates of smoking are people with substance use disorders and people in recovery from substance use disorders. So I want to just show this to you in another way to kind of give you a sense of the scope of the problem of smoking within a behavioral health population. So if this picture represents everyone in the United States, we know that 1 in 5 of all of us will be diagnosed with or experience a mental illness or a substance use disorder in our lifetime. So 20% of all of us will fall into this category. And this picture shows, let's pretend that this is all the cigarettes consumed by someone in the United States in any given year. 45% of cigarettes are smoked by someone who has a mental illness or a substance use disorder. This is speaking broadly about any kind of mental illness, and so we know the rates of smoking are particularly high in certain subpopulations. For example, people with serious mental illness, schizophrenia, bipolar. And a group that has a very high rate of smoking are people with substance use disorders. And so what happens is that now that we have, been so successful and really driven down the smoking prevalence in the general population, we see that tobacco use is not an equal opportunity killer. We lose people disproportionately to tobacco-related death, disease, more who are poor, who are homeless, who are LGBTQ. And for the purpose of today, we're focusing on people who have a substance use disorder. This is another way to look at it. We know, of course, our rate of smoking among the general population in Kentucky is higher than this, but if we were to look across the nation, we see now about 17% of adults smoke. Well, when you look at having a substance use disorder, it's up over 60%. And really, again, we could drill down further and think about other substances. For example, people who are former injection drug users, it's up in the 90% of people who currently smoke, and oftentimes that stays the same when people enter into recovery from substance use disorder, which I'll touch on. So tobacco use is an overlooked epidemic among people with substance use disorders. And this is something that probably sounds like I always get on my soapbox to talk about, but I am very passionate about this. And we have certainly made progress. I like to just give the anecdote that when I first started working as a nurse, I worked in a state-run psychiatric facility, and this was a little more than 10 years ago. But as a nurse, we took our patients out to smoke. So we pretty truly felt like people with serious mental illness, substance use disorders, they just could not stop smoking. And we know now that that's not true, and we've made progress. And so we just need to make more rapid progress so that people in this community don't continue to face this disproportionate death and disease. And one of the reasons that we don't make faster progress in this area is because of persistent myths. And so people will say, well, people with substance use disorders, they don't want to quit smoking. Well, that's not true. There have been studies that show that among people with substance use disorders, it's exactly the same as in the general adult population. 80% of people, all people, even if they have a substance use disorder, want to quit smoking. They wish they were not smokers. So we're going to talk a little bit more about these persistent myths. You also hear, if you work in or around the behavioral health community, that smoking is a low-risk priority. And I can see where that comes from, because a lot of times when we think about addiction, what we're thinking about is the person in active addiction in a very bad place. So certainly there are times when smoking is not someone's priority, when housing and sobriety, and there are other things certainly that might be your priority, but people go on, hopefully, from their time in addiction to living a life in long-term recovery. And there needs to be some time when we as a community feel, are actively providing evidence-based tobacco treatment for people in treatment and in recovery from substance use disorder. And just to sort of counter the idea that smoking is not important, the people who are addicted to alcohol, have an alcohol use disorder, they are more likely in their life to go on to die from a tobacco-related disease than an alcohol-related disease. Among people with a substance use disorder, people in remission, those who smoke are 4 times more likely to die early compared to those who don't. And a meta-analysis has shown us that smoking cessation has been linked to a 25% increased likelihood of long-term abstinence from other drugs and alcohol. We also hear, I'm sure you all hear this a lot, that smoking cessation, you need somebody feels that they need to smoke because they're anxious. This is something that is particularly prevalent when you work with behavioral health clients. People feel like, they already have so much anxiety, how could someone quit smoking? But while smoking cessation, the act of stopping smoking is stressful, it's difficult. We know that when you can get on that other side of that successful cessation is actually associated with lower rates of depression, lower anxiety and stress, and actually an improved positive mood and quality of life. Same for a person in recovery from substance use disorders, that if they can cross that hurdle, if we can help them quit smoking, it really would be associated with a reduction in that anxiety. So It's a big task, right? How can we go out and address the epidemic of tobacco use among people with substance use disorder? Remembering that people in this group, just like every other group, really want to quit. How can we help? I'm going to talk about 3 different ways. So one is to integrate tobacco treatment and policy into treatment. So when someone comes in, they're seeking treatment for their substance use disorder, we can treat tobacco use right along with their addictions to other drugs and alcohol. We can move away from our silos to broaden addiction coalitions. And we can also shift our focus of substance use disorder from crisis stabilization and treatment to long-term recovery. I'll go into more detail about what I mean about that in just a bit. So I'm going to first give you an example of a partnership that the Perinatal Research and Wellness team here at UK conducted with some local women's treatment facilities here in town. So to start, several years ago, we were looking at the research literature. We wanted to partner with the Chrysalis House. They've been very interested in helping the women that they serve to quit smoking. But we asked ourselves, what could we do to help women with substance use disorders stop smoking? Because we know that people want to quit, but we also knew that the rates of success were not super high, and we wanted to be able to create something tailored that would really be maximally effective for these women. So we started with formative research. And I went in with some research team members, and we sat down, we had focus groups and interviews with women who were living in a residential treatment facility for pregnant and parenting women. We went ahead and expanded that to try to help us understand the phenomenon of smoking and tobacco treatment among women with substance use disorders. So we did a few more focus groups at an outpatient treatment clinic. Again, this was specifically for women who are pregnant and immediately postpartum with an opioid use disorder. And finally, we went ahead and did some interviews with women who had their infants are being cared for in the NICU and they were being treated or evaluated for neonatal abstinence syndrome. So we talked to those women as well and asked them, talk to us about your smoking, what would it really take for us to help you, quit smoking at this time when it would really mean a lot to the health of your family and your infant. So we have been working with the Chrysalis House since January of 2015. It's been great to really work in the same, community and to really get to know the women and the staff. Again, though, we didn't just start doing an intervention. In addition to all those focus groups, we went out and recruited women to work with us to help us understand smoking there. We did a photo voice project where people took pictures of the things that triggered them to smoke and also the things that triggered them to have healthy activities. So we had a lot of people talking to us about the smoking porch and, being around other people in treatment that smoke. We did something called a social determinants mapping where we had some volunteers sort of draw out where they went on a day-to-day basis and kind of mark where they smoked. And we had people start doing some cigarette tracking, just even if they didn't want to quit, just to tell us, kind of evaluate each cigarette, why, when were you smoking, why were you having that cigarette, was it a craving, was it boredom, just so we could really feel like pretty invested in our understanding of smoking in this facility. So these were the formative results of our research, and I'll give you a few quotes because I think it brings it to life more than me talking about it. But as we expected, most people that we talked to, they did want to quit. The vast majority wanted to quit. The first reason they would say was the health of their baby, their other children. Also the cost. We're talking about people who are oftentimes really struggling to make ends meet, and they were aware of the money they were spending on tobacco and wishing that wasn't the case. However, they were acknowledging these really complex barriers that they would face to quit. They do have these super high levels of stress and a fear of tackling dual addictions, a fear of that persistent myth that if you try to quit, you might relapse. We asked people to tell us about a time that they had quit smoking. And interesting for me or eye-opening was both of them talked about a time that they could not smoke because they were in a tobacco-free hospital, such as during their delivery, or that they had been in a prison, incarcerated, and unable to smoke. They felt that they would need really intensive support to quit. They'd had lack of success in the past, despite To be fair, though, not having participated in perhaps an evidence-based tobacco treatment, but had not been successful in the past, several of them talked about wanting a support person they could call, like their sponsor, and that they felt that they could trust nurses, pretty well in the healthcare system to provide their care, as long as they were engaging in non-judgmental care. But the vast majority of them had very positive experiences with their nurses. So these are just a few quotes because, again, I think it's better. I want to let the women, speak for themselves. But this person says, I definitely would love to quit before my child gets here. I'd give anything if I could put cigarettes down. Anything. Here in this facility, smoking is a social medium. I know that I sometimes feel left out because I'm the only one in this house who doesn't smoke. If we just cut that out, smoking, that would make the door to relapse just maybe oil the hinges a bit, help that door open. I went to a long-term rehab treatment last year. The first 10 days, you're not allowed to smoke cigarettes. So 10 days I hadn't smoked. So I said, well, I'm just going to quit. And they, the staff at this facility, told me they don't recommend that. They don't recommend you to quit smoking until you've been in recovery for a year. So what all of this led us to was an innovative partnership with the Chrysalis House. The first round of this, the first pilot, the partnership was also with the YMCA and the Kentucky Quit Line. And we decided to design a program that really took into account what the participants had asked for. They wanted a non-judgmental, safe space where they could get support from other women who are trying to quit. This program is led by fantastic perinatal nurses who really create that non-judgmental space that women ask for. So there's the 45-minute of the typical tobacco treatment content, but then the rest of the time there is group physical activity. So the idea was to go ahead and show and introduce participants to another way to cope with stress. So if for people who participated in this program, they got the free YMCA membership. It was for themselves and their family for 6 months and a physical activity tracker. And I won't go into great detail about this, but just to show you that it is possible to work together to really provide kind of a win-win situation. We had help from the Y, we had help from the Quit Line. These are a few of our research team and our community partners. And it just was a really nice opportunity to be able to bring people into the Y, which is such a positive family place, and just to kind of get people acclimated to other ways to reduce stress in a really non-judgmental way. So this is one of my favorite things that we do all day. And this is no longer the case, but when we first started offering this program, it was super helpful. The Kentucky Quit Line was able to offer that any participant who was in Get Fit and Quit could get NRT for free. It was great, and it really broke down some of those barriers for people who are not uninsured, but who were on Medicaid and really still had just that extra barrier of getting the prescription for their NRT. So this was another great thing that we were really thankful to the Quit Line for. And I will not go too much into this because I really just want to show you a case example of something that you might want to implement in your community. But in our first pilot, we found that we had 3 people who actually stopped using traditional cigarettes, 2 who were continuing to use e-cigarettes. But we really did see that reduction in cigarettes per day, a reduction in the stress and depression levels, and we had positive feedback as well when we asked people, what did you like about Get Fit and Quit? Someone said having a quit date, something to look forward to, believing in myself, and having healthy coping skills. Another person said having a support group that actually talks about our severe addiction to smoking. Our dependency on cigarettes is always swept under the rug. And someone else said the ladies, the study nurses, support friendship and how comfortable and easy it was to open up and discuss difficult topics with them without the fear of them judging us. And so I think a happy outcome of this pilot is that we now have a 5-year contract working with the Chrysalis House to continue offering this. And so I would just hope that maybe from hearing this, you might think about ways that you could also partner with a local treatment facility to provide some cessation options. I'm going to change gears now. That was a case study, and I'd be happy to, give you any more details about that you're interested in. But I also want to present this idea to you that we have broken up into silos unnecessarily in public health. And so for those of you who go to public health conferences, which I bet is almost all of you, or those of you who go to APHA, you know that our section is alcohol, tobacco, and other drugs. And even when you submit an abstract, if you wanted to present at these kind of conferences, they will ask you, are you alcohol, tobacco, or other drugs? And so I want to ask you to think about that and to say, why is it that we separate out and we put into silos alcohol, tobacco, and other drugs? Are we just talking about drug use? And what about all of the ways that they really overlap? So I argue that we've created unnecessary silos, that a lot of us, really when we work in only one area, when we work in tobacco or other drugs or alcohol, that we miss these really complicated connections between the substances. They're all addictive drugs. Just an example, this is Rachel, she's hooked. But what does that have to do with other drugs? Well, among people with substance use disorders, over 90% of them began smoking, drinking, or using other drugs before the age of 18. We know smoking is oftentimes the first drug, especially here in Kentucky. It's usually your very first drug that someone's going to try. And we know, all of you who provide tobacco treatment, you've, I'm sure, seen this, that sometimes you have a person who has a tobacco addiction, and it's social drinking that makes it hard for them to quit. So they quit all week, they go out to a bar with their friends, they have a drink, and they relapse. And we know for sure that drinking complicates smoking cessation. It reduces your inhibition some, but really we're talking about drugs, we're talking about stimulating the brain. There's just so much overlap between them. However, I've also seen when it comes to silos, people try to pit the substances together. And here's an example. Someone said, the deadlier drug crises that we don't consider public health emergencies. Alcohol and tobacco kill more people than opioids, or cigarettes kill more people than the opioid crisis. And I would recommend against this as well. This is another example, in my opinion, of putting it into silos and saying, like, well, oh, the opioid crisis is important. No, the tobacco crisis is important. Well, they're all important, and they're also interrelated. So I think a better approach is to try to raise awareness and say, we're all serious about the opioid epidemic, and it's terrible and tragic. And what if we broadened our coalition instead by saying, while we're treating opioid addiction, we need to treat nicotine addiction as well. And everyone, really more, come together, share resources. And another way that works is if we shift our focus from crisis stabilization to recovery. So in the beginning of when I started this talk, I said, yes, we think that tobacco use is not an important topic for people with addiction. And that's because a lot of times in your mind, what you're thinking of as a person, you're thinking of a person in active addiction. So yeah, that person living under the bridge, injecting heroin, that's always an example that people give about tobacco use is not their priority. You're right, but that person will enter treatment, and then we really hope that what they'll do is enter a maintenance phase and live a life in long-term recovery. And at that time, at treatment and recovery is when it's important to help people be able to live the best life that they can live. And we have to shift our focus when we talk about addiction from just that crisis stabilization phase to recovery, and that is where tobacco treatment fits in. Long-term recovery supports are needed in general. So this is another one of my soapbox topics. So sorry I'm sort of holding you hostage and talking to you about it, but we, again, by focusing on crisis time, we don't realize that, we realize this, the relapse rates are high. It takes someone until they get out to almost 5 years to really level off where they are not at a pretty high risk for relapse. And during all that time, we need to be helping them, give them the tools to put into place to sustain their recovery. So then what is recovery? Let's say we're shifting away from crisis. What's holistic recovery? It's a process of change through which individuals improve their health and wellness, live a self-directed life, and reach their full potential. So again, this is where we would think about holistic health, think about the way that someone can be supported to reach their full potential. So holistic recovery, health is a big thing. For someone to really, enter into and sustain a holistic recovery, we need to promote their health. Tobacco treatment fits right in terms of supporting someone's health and their ability to live in long-term recovery. Another thing about holistic recovery that we don't think about as much is the role of the community. So there are lots of ways that a community can help people be in recovery. So one way is if we reduce the stigma of addictions, we can help people be in recovery. If we help people, we create policies where people in recovery can get jobs. That's an example of creating a community where people can recover. But you're all in tobacco control, and there are lots of ways that we make the community a place for people who want to stop using substances, such as smoke-free laws, tobacco taxes. All these things would also help someone in recovery from substance use disorder as they try to quit smoking. And as an aside, it is actually, like I mentioned, I am on the board of Voices of Hope. One of our missions is to create a community that is supportive of people as they try to maintain long-term recovery, so their highest level of holistic health. And you know this one, so what you all can do to help with creating that community that's supportive is all the things that you're already doing. That's awesome, right? So we need the smoke-free laws, we need access to cessation, we need the tobacco, price to go up, and we need hard-hitting media campaigns. So now, when we go back to this question, hopefully it doesn't seem quite so big. How could we address the epidemic of tobacco use among people with substance use disorders? We can try to integrate tobacco treatment and policy into those treatment facilities where you are. Is there a way you can reach out and partner with them? I feel we should move away from silos and try to broaden our coalition so that everyone who cares about addiction is working together, because it is one disease. And that if we shift our focus from crisis to supporting long-term recovery, we would see more people able to really stay and live and thrive in recovery from their disease. So to end, I want to show you one of my favorite ads. It's from the Cigarettes Are My Greatest Enemy campaign. You can download all their flyers if you're interested in any. And this is Selma, and she says, "I didn't survive drugs and alcohol so I could die from lung cancer. I had to stop smoking." If you have any questions, I'm available now, but you can also send me an email at amanda.fallon@uky.edu. Thank you so much for your time.
Thank you so much, Amanda. That was great information. I know when I talk to the health departments, a lot of them work with their local ASAP groups, and they'll say, oh, they used to provide nicotine replacement therapy, but now everything's about heroin, and for a while everything was about meth. So I really like the message about being more collaborative and not siloing, because in a lot of ways addiction is addiction. You need to treat all of it. At this time, I'm not seeing any questions on our screen. But like Amanda said, if you have any questions, please feel free to email her. Her email address is up on the screen. And this webinar is being recorded, so we will be able to send out a recording of this for anyone who wasn't able to make it live. So thank you very much, Amanda. One note, our next webinar, we're still going to be using GoToWebinar, but instead of using the account for the cabinet, they've given me my own personal account. So if there are any technical difficulties with next month's webinar, I'm just going to go ahead and apologize ahead of time. In the meantime, keep your eyes open for our new campaign, our new media campaign promoting the Quit line. Tell everyone to call. And if they are uninsured or have Medicare, then they do get free nicotine replacement therapy for 4 weeks. It used to be 8 weeks, but right now it's 4 weeks. So with that, thank you very much, Amanda. Have a great day, everybody.